would like to invite Dr. Sumit Grover. He will talk about quality assurance and monitoring related in relation to cataract surgical outcome. Sumit.
Thank you. Thank you so much, sir. A very good morning to all of you. I think we have all, got the crux that effective cataract surgical coverage is important. It is not important the quantity of the cataract surgeries which are being done in the country, but the focus should be on the quality. I'll just go through quickly through this slide that India is going to the late transitional stage. We have a large population of elderly, so there will be by default large prevalence of cataract. But we are in the age of femtosecond cataract surgical techniques are there. We have multifocal IOLs, we have clarion, things like that. And the cataract surgical rate of the country, specifically some states of Gujarat, is like more than 16,000. But and also the point to be highlighted is the cataract surgery is shown to be one of the most cost effective surgery, in terms of dailies, in terms of qualities. It's very cost effective. But uh, we have to see the cataract surgical outcomes as well. The cataract surgical outcomes depend upon two things, like quantity of the cataract surgery has already been covered by Dr. Praveen Vashish, that there is cataract surgical coverage, and other things also can be calculated, like average weekly output per cataract surgeon, annual output per cataract surgeon. But all these things quantify the how much cataract surgeries are being done. But the quality of the cataract surgery matters, because there are many studies, qualitative studies in the survey cross sectional study, which states that in any area, if the cataract surgical outcomes are poor, then there, by the word of mouth, the cataract surgical services demand decreases. So, it to maintain and sustain and enhance the surgical uptake within the programs district in the states, maintaining the quality of cataract surgery is imperative. How the outcomes in the healthcare are defined, it was being elaborated by Don Bedian in his study, and he stated that these outcomes are related to both the structure, the infrastructure of the health system, as well as the process. The process means the interaction between the clinician and the patient, both in technical and interpersonal. And they suggested that all the components of this care pathway, starting from the consent for the cataract surgery to the surgical technique itself, they we should focus on them. And another aspect of cataract surgical outcomes are the patient factors and the service related factors. Patient factors are those factors which are very specific to each patient and are not related to service provided. They are ocular comorbidities, etc. But however, there in certain instances, especially the PCO, the visual outcome can be improved with the service provision. On the contrary, the service-related factors are those which are not related to patient comorbidities and can be directly preventable by the altering the services. So, poor visual outcome as a result of surgical complication or faulty biometries, these are service-related factors. In late 90s, some population-based survey showed that up to 40% of the operated cataract patient could not see 660 after cataract surgery. In response, in 1998, there was an informal consultation which was held in Geneva, and WHO published these criteria. This is very important for the resident as well as for all of us, that according to WHO, fewer than 5% of the cataract patient should be unable to see 660, best corrected or presenting, in both the presenting as well as best corrected. And more than 80% should have presenting visual acuity more than 80%, and best corrected more than 90%. uh, in this informal consortium, it was the good outcome was defined by 618 or better. But in the recent publication by WHO and many committees, the recommended threshold for defining good outcome was presenting visual acuity of 612 or better, not 6 by 18. This change was very much thoughtful, because it was shown that there was a growing body of evidence that mild visual impairment, which is visual acuity less than 618 to 612, has a notable impact on one's life. And presenting visual acuity and not best corrected visual acuity was used because it reflects the individual's visual acuity in everyday life following the surgery, and it also allows for the deficiency in intraocular lens availability or faulty IOL power calculations. So we have to now understand that the recommended threshold is presenting visual acuity better than 612. It is the visual acuity is the most easily measured indicators, and there are many tools, automated as well as manual, which calculates the pre-operative visual acuity surgical technique used, whether it's phacoemulsification, SICS, or ECCE, whether the outcome is good, borderline poor, both in surgical visual acuity at just immediate post-op and after the follow-up, type of complication, and major cause of the each poor outcome. But in lower and middle income countries like India, the major limitations for this visual acuity measurements using as a clinical indicator was the poor follow up. Although there are many studies which used that, for example, the Congdon et al. They reported that early post-operative visual acuity measured within 3 days after cataract surgery was closely correlated with the final follow-ups. But it was also emphasized that late follow-up examination and mid-term follow-up examination were also very important, which we lack in our setup. So another clinical indicator which can be apart from the visual acuity is the effective cataract surgical coverage, which has been very much comprehensively elaborated just now. So I'll just skip through. There were many studies like from the developed nations like Denmark. They used another indicators, clinical indicators, and not just the presenting visual acuity after the cataract surgery. They used pseudophakic retinal detachment and post-operative endophthalmitis incidence and prevalences as a proxy indicators for quality of surgical outcomes. However, these things are not feasible in India because they have a very diligent registries, cataract registries they maintain in Denmark, countries like Denmark, which are very much lacking in India. This population-based indicators from RAF survey, these are all the clinical indicators like effective cataract surgical coverage, which we can take out from this cross-sectional surveys, which has already been emphasized. We know that clinical outcomes like visual acuity, the pseudophakic retinal detachment, and endophthalmitis are relatively simpler to measure and quantified. They can be standardized across the hospitals. However, they cannot be used in isolation because, as we have seen, that the preoperative morbidity or the patient factors and the clinical factors both are important. And this concept, which is known as the case mix, which has been published by the LV Prasad Eye Institute in India. Now, apart from the clinical indicators, in the end, a patient-reported outcome is also can be used as a outcome indicator for the cataract surgery. But these patient-reported outcomes have some limitations, because a patient can report good outcome without improvement in clinically assessed indicator like improved vision. Conversely, a vision can improve without the patient reporting an improvement in quality of life, because these patient reported outcomes are very subjective. They cannot be quantified and compared between the two districts or the two clinical setups. So the mixture of the PROs and the clinical indicators, which are patient report indicators and clinical indicators, are always recommended. And also the validation of these patient reported outcomes questionnaire is also a very much things to is very much relevant, because if it is PRO questionnaire is validated for one set of population, it is not that it will be feasible for the others, another set of population. So the monitoring is a critical component of improving outcomes. A regular medical audit by the service provider is a good way of monitoring clinical outcome, but unfortunately, many ophthalmologists like us, we are very much reluctant to use monitoring tool available. We take things in personal, and there is a resistance from the medical staff that they feel that the monitoring outcome is a measure of their performance, which is not true, actually, and these barriers must be identified by qualitative studies and should be overcome to incorporate monitoring of outcomes into routine practice. And very much well quoted example of this quality assurance is the Arvind Eye Care system, where they have a efficient, they deliver high quality, efficient cataract surgery in southern part of India. And what is the conclusion? What we can learn from the Arvind Eye Care system and many other high volume cataract surgery things? The training and empowering the non-ophthalmologist human resources, optometrists, trained nurses, they are all doing the quality biometry in all these setups. Knowledge and awareness of the patients, they should report, there should be a felt need of getting cataract surgical services, uptake should be good. High quality care will increase the demand, because cataract surgery is word to mouth publicity. When there will be efficiency, there will be volume. High volume will decrease the per unit cost, which will be economically efficient, and this can be done by local production of the consumables, which is example is Arvind Eye Care system, again Orolab. Then tiered pricing system, altruistic goals, self-serving goals. There should not be only the self-serving goals of the organization and not only the altruistic goals. And these cataract indicators monitoring process should be incorporated in the practice. And there should be a good quality data and careful interpretation by clinician and program managers in order to identify that which aspect of the cataract services is the limiting factor and should be taken care of. Thank you so much for the patient listening.
Thank you, Sumit. In fact, very nicely you elaborated all the indicators related to quality of cataract surgery. In fact, we have come a long way actually. I remember in 2001 when national survey was conducted. At that time, the findings were that nearly 33% patient were blind after cataract surgery. 33%, and that is those surgeries which were conducted in camps. And as a result of that, Government of India stopped that all the outreach camp surgeries should be stopped immediately. That was the message. The policy decision was taken at that time. When we conducted this 2015-19 survey, we found that the coverage is very good. But when you talk about the outcome of cataract surgery, and if you take a cutoff of 6 by 12, 57% surgeries, they had visual outcome better than 6 by 12. That means the rest 43% surgeries, the visual outcome were worse than 6 by 12 in country. Gujarat is one state which are doing maximum number of cataract surgeries. Their cataract surgical rate is 16,000 surgeries per million population per year, against a country average of 5,000. But what we found there in Gujarat, that one of the important, in fact, second leading cause of blindness in Gujarat was the complications of cataract surgery. 25% of the patient, the cause of blindness was complication of cataract surgery. That means we have to give emphasis. If we are increasing the number of cataract surgeries, we need to give emphasis to outcomes, the quality of cataract surgery. To overall summarize this session, I must say that the WHO has come out with very good indicators. That is two indicators: that is effective cataract surgical coverage and effective refractive error coverage. These are the global indicators. Each and every country have to maintain this indicator, and these are not quantitative indicators. In fact, they also give qualitative cataract. So all other indicators combined together can be taken as one indicator, that is effective cataract surgical coverage and effective refractive error coverage. Probably in India, as I mentioned, that we are able to give some information about effective cataract surgical coverage, but even at this stage, the data related to effective refractive error coverage is very low, and in fact, we need to plan some studies. The study which we have given here is also approved by NPCB, National Program of Control of Blindness. It is approved by WHO CRO, Southeast Asia region, and it is under consideration with WHO Geneva. So that is something where we are expecting that each and every distant country should be able to provide data related to these indicators. And ultimately, then we can plan what we have to achieve by the year 2030. So we hoping this thing that all the district managers, district program managers, state program managers, they will understand this concept, and then they will try to achieve these things. Thank you very much. We are really thankful to AIOS for giving us permission and chance to have this instruction course. Thank you very much.